Hello everyone, welcome to your lecture on fluid and electrolytes. These are the learning objectives we will be covering. Let's talk about homeostasis. What is homeostasis? It's the body's ability to maintain a stable environment in terms of volume and composition of its fluids, right? We need a balance of fluids, electrolytes, and acid bases for your organs and cells to function properly. The organs that are involved in maintaining homeostasis are kidneys, lungs, heart, adrenal glands, parathyroid glands, and the pituitary gland. Now, all of these help to maintain that fluid balance. Remember, with the cardiovascular system, the kidneys, help to maintain, balance in the body by the RAS system, right? When the blood pressure is too low, the kidneys secrete renin, and the renin becomes angiotensin, then angiotensin 2, and then it helps to constrict the vessels and increase the blood pressure. And, and also we have the antidiuretic hormone, which gets, released from the pituitary glands. Then also, from we get the other hormones, aldosterone, that also helps to retain the fluid. So the same way, that's exactly what the kidney is doing to maintain homeostasis. Other things that the kidney does is filter blood. Obviously it adjusts fluid composition and the volume. An average healthy adult has about 5.2 to 6 liters of circulating fluid in the body. It maintains and excretes body fluids. How does it do this? Through urine, about 30 milliliters per hour, which is about 1 to 2 liters of urine a day. It regulates sodium and maintains pH levels by excreting and maintaining hydrogen ions and bicarbonate. It also excretes metabolic wastes and toxic substances. It also plays a role in manufacturing erythropoietin, EPO. This is a hormone which helps to maintain the amount of erythrocytes or red blood cell counts to maintain oxygenation. So patients who have kidney failure and who are on dialysis, they are given EPO, injected with EPO, so to help them maintain the red blood cells. Lungs also play a role in homeostasis. They regulate carbon dioxide through gas exchange. They influence acid-base balance, water loss through respiration. At about a temperature of 35 degrees Celsius, which is about 95 degrees Fahrenheit, we lose approximately 7 milliliters an hour through our respiration, right? But temperature changes can affect this, sorry. The heart, how does the heart maintain homeostasis? We talked about this in cardiovascular system. The heart pumps sufficient blood to perfuse the kidneys. Sodium, potassium, calcium, all are very crucial in maintaining the electrical conductivity and the pumping action of the heart. Adrenal glands, what do? They secrete aldosterone, just like in the RAS system, right? When blood pressure is low, it retains sodium and water, and it helps to increase the blood pressure and potassium excretion to maintain homeostasis. Parathyroid glands. It regulates calcium and phosphorus levels in the blood by increasing and decreasing parathyroid hormone, which influences the transference of calcium and phosphorus from the bones. Then we have the pituitary gland. This secretes ADH, the antidiuretic hormone, which causes the body to retain the water by signaling the kidneys to increase water absorption when filtering the blood, which in turn helps to regulate blood pressure. So all of these are helping maintain homeostasis. Now, a lot of these, they kick in when the blood pressure is low, right? When your volume is low, they kick in. What happens when your volume is high in the body? And even when we mention like the RAS system, your blood pressure is low and the RAS system kicks in. When your blood pressure is high, to decrease the blood pressure, what happens? The heart releases ANP and BNP, and I could never pronounce this, atrial natriuretic peptide and brain natriuretic peptide, right, BNP, right? These are released from the atria and the ventricles, and what these hormones do, they indicate the, hypervolemia, too much volume in the body, and the stretch of the heart muscle. And that's the reason why they're checked when, patients are suspected of having, chest, a heart attack. So what happens when those are released is that it causes vasodilation and helps the blood pressure to decrease. So the RAS system increases the blood pressure, and the ANP and BNP are the ones that, decrease the volume. Okay, let's move on. The body fluid balance. So these are some important terms and definitions that you should be aware of and be familiar with. What is osmosis? It's shifting a fluid from lower concentration to higher concentration of solute through the membranes, separating them, right? And what is osmotic pressure? The ability of solution to draw water across a membrane. So these are all very important definitions that you should be aware of, and it's part of anatomy of the body. So where is this fluid that we have in the body? We say the body has so much fluid. Where is this fluid? It lives in the intracellular, inside the cells, intracellular fluid, and that's about 2/3 of the water in your body. 2/3 of the fluids in your body live inside the cells. Extracellular is outside the cell membrane, which is about approximately a third of your body's fluid volume. So intravascular liquid is part of, for example, intravascular is the liquid that's part of your blood or your plasma. Interstitial fluid lives between the cells, outside of the blood vessels, and the lymph fluid. Transcellular is secreted by epithelial cells. And for example, your, CSF, your cerebrospinal fluid, your pleural fluid, your peritoneal fluid, your synovial fluids, all of those are your, fluids that are in the body. So the transcellular fluid, what are these transcellular fluids, right? These are the ones that are, like I mentioned, they're in your spine, your pleural fluid, your peritoneal fluid, it's surrounding your joints and your synovial fluid. And it's important to know the composition of where these fluids live. Then we have what are indicators of fluid loss? How do we know if the patient is losing fluids, right? We have to collect data, then we get their, all their subjective data, but then we need to do some labs. So we check BUN, the blood urine nitrogen, remember, for kidney function. Then we check the creatinine. You want to check the glomerular function. Then you want to check urine-specific gravity. Then you know how concentrated the fluid is in the body, right? So balance is maintained through what? Input, thirst sensation, social factors, personal habits, how much you drink, right? So input and output. So output through the kidneys, with urine, the skin, lungs, GI tract, all of that is your output. So let's talk about edema. Now we're talking about fluid. We talked about, maintenance of the fluid. We talked about the different types of fluid, where the fluid lives in the body, right? Now, what is edema, right? It's an excess accumulation of tissue fluid. If it's accumulating everywhere in the body, it's considered systemic edema. If it's accumulating in specific areas, then it's, called, the name given to it is based on where the fluid is accumulating. For example, if the fluid is accumulating around your lungs, then it's called pulmonary edema. If the fluid is accumulating in your abdominal area, then that's called ascites. If the fluid is accumulating in your periphery, for example, your feet, your legs, then it's called peripheral edema. And if it's accumulating in your pleural space, then around your lungs, in your pleural space, then it's considered pleural effusion. So edema is when there's more fluid in the extracellular space, where, the fluids remember we said most of the fluid lives in your intracellular space. So when it goes out of the intracellular space, too much of it goes into the extracellular space, that's what causes the edema. There we go. What are the major causes of edema? You have remember we talked about, in your cardiovascular lecture, we talked about arterial blood pressure, right? It's about approximately 90 Normal is approximately 90 millimeters per mercury. Now, what happens when and we also mentioned that if that pressure increases, it can cause what? It can cause the capillaries to leak, right? And so it causes when edema causes increased capillary blood pressure. So when that happens, more water is going out of the vessels in the capillaries into the tissues than normal. This leads to edema. For example, people with hypertension have edema. So the first line therapy is what? Diuretics. We give them diuretics, reduce that volume, reduce that preload, and reduce that arterial blood pressure. If the arterial blood pressure is low, for example, in hypotension during shock, what happens? The capillary blood pressure will also be low, right? So this causes decreased water filtration of water out of the capillaries. That means not enough fluid is escaping the capillaries to go to the surrounding tissues and the organs. And what happens then? Then it leads to dehydration. So the major causes of edema, for example, also another cause of edema or dehydration is the lymphatic vessels, right? What if the blood pressure is okay? The protein level is okay, but the lymphatic system is not working. Remember, we said, what does the lymphatic system do? It takes that extra fluid in the body that's being that comes out of your capillaries, and it puts it back into the venous system so it can get to the heart to be oxygenated again, right? But what if your lymphatic system is not working? Then what happens? Then you have obstructions in the lymphatic system, right? You can have obstructions, which are, for example, lymphedema. You have elephantiasis. It's caused by a parasitic worm that multiplies in the lymphatic system and obstructs it and causes it to swell. You could see a picture right here. Cancer. It spreads through the lymphatic system. So when a patient has cancer, the lymphatic vessels in that area are removed because then the fluid accumulates there. Okay, so let's talk about dehydration. What is dehydration? It's loss of water and solutes, mainly sodium. It's in roughly equal quantities. That's the way it exists in blood, right? In equal quantities. So dehydration can be of different types. The first type can be hypotonic or hyponatremic, right? This is primarily loss of electrolytes, mainly sodium. This happens when intravascular water shifts to the extravascular space, right? And then you have hypotonic or hyponatremic dehydration. And this can cause seizures, cerebral edema, and especially upon rapid rehydration. When we're trying to rehydrate them really fast, then it can cause neurological issues. Then you have hypertonic or hypernatremic dehydration. This is primarily the loss of water. It can also cause seizures and cerebral edema as well, especially when you're trying to rapidly rehydrate the patient. Any shifts in sodium actually can cause neurological problems. Then the third type is isotonic or isonatremic, aka also known as hypovolemia. This is when there's equal amounts of water and electrolytes lost. This is the most common type of dehydration. Causes of dehydration. They're hyperventilation, you're breathing really fast, excessive sweating without drinking water, right? You're sweating a lot, but you're not inputting water. Prolonged fever, because remember, fever increases metabolic demand on the body. And so you can get it can cause dehydration. Diabetic ketoacidosis. That is a serious complication of diabetes that occurs when the body doesn't have enough insulin in it. You can have insufficient water intake. Some people, do not get enough intake of water. For example, you have enteral feeding. You're giving a patient has a PEG tube or giving them feeding through a PEG tube, but we're not giving them water. It can cause dehydration. Decreased thirst sensation. This happens in the older adult, or aphasia. There are a lot of reasons why, that can lead to insufficient water intake. Then you have diabetes insipidus, can also cause dehydration. What is diabetes? It's a disorder that affects the body's ability to regulate water balance. So what happens is you're excessively thirsty, but you're urinating a lot. not, right? You have, abnormal amounts of the antidiuretic hormone, and so you're just, diuresing all the time. Osmotic diuresis can also cause dehydration. This happens also a lot in people who are high levels of blood sugars. Excessive intake of salt tablets, or hypertonic IV fluids can cause dehydration. Rehydration. How do we rehydrate these people? But in mild cases, it's just oral rehydration, drinking water, PO intake. In severe cases, they need IV replacement. They need isotonic, hypotonic fluids to help replace the fluids. But remember, it's done slowly. It's not done rapidly because it can cause neurological problems or cerebral edema. So you have two different extremes. You can have fluid volume excess, and you could have fluid volume deficit, right? So fluid volume excess, hypervolemia, right? This is when the body retains water and electrolytes isotonically, that's hypervolemia. You can have fluid overload, water intoxication, excess fluid and water, increase in water and sodium in the body, right? What are some causes of it? Heart failure, liver cirrhosis, excessive ingestion of table salt. Overhydration with sodium-containing IV fluids can also, cause this as well. How do we treat this? We reduce the fluid. They have too much fluid in their body, so we reduce the fluid, right? And then we, we reduce the fluid and we maintain the electrolyte balance. As you're reducing the fluid, you also want to make sure that the electrolytes are balanced. Then you have fluid volume deficit. This is when there's a loss of fluids and electrolytes, right? Isotonic, hypotonic, hypertonic. It can be acute or chronic. What can cause this? Excessive GI loss. How does this happen? Through vomiting, nasogastric suctioning, diarrhea, excessive skin loss through diaphoresis. You're sweating a lot, right? Without sodium and water replacement. You could have a wound that's draining a lot, right? You could have excessive renal losses through diuretic therapy, kidney disease, adrenal insufficiency, right? Then you can have decreased intake, inability to drink water. Older adults, they forget to drink water. They lose that sensation of thirst. You could have oral trauma, so you cannot take in water. Altered intake, you can have altered intake, for example, anorexia, nausea, impaired swallowing, confusion. Or if you're a patient who has been put on nothing by mouth, NPO status, because you're supposed to have a surgical procedure, or there's some other problem going on, that can cause, a fluid volume deficit. If you have hemorrhage or plasma loss, for example, when, if there's a patient that's got into a car accident or an accident and they're hemorrhaging, they can lose plasma, and that can lead to fluid volume deficit. Third spacing, when a person has burns, you can have third spacing, right? That means third spacing is when your fluid, instead of being in your intravascular or intracellular, is actually outside in the surrounding tissues in your body. And for example, like ascites, right? So these are all causes of fluid volume deficit. What is our treatment goal? Our goal is to treat the underlying cause, replace the fluid, and correct any electrolyte imbalances. This over here is a chart that compares both fluid volume deficit and fluid volume excess. Please go over this. This shows the assessments that we're going to look for in people who have, both of these extremes. If you notice, I highlighted the complications. Those are important to remember as well. These are the labs right here. As you're checking for labs and diagnostic, that's your objective data, right? And if you notice here, what happens? Your hematocrit is increased in fluid volume deficit. Now your blood is more concentrated, right? So because you don't have enough plasma in there. And so you're going to have increased hematocrit. Your BUN, your kidney function is going to be off. You're going to have increased BUN and creatinine. You're going to have an increased urine-specific gravity. You're going to have increased sodium in your blood. You're going to have increased blood osmolality and serum osmolality. osmolality. Basically, that's hemoconcentration, right? Shows hemoconcentration. Then over here, when you have fluid volume excess, now your blood is more diluted. So you're going to have decreased amount of hematocrit and hemoglobin, osmolality, urine sodium, and specific gravity, BUN, is going to be, decreased, lowered. The chest x-ray might even possibly reveal pulmonary congestion because of too much fluid in your body. So these are some nursing interventions, extremely important to remember. And this is some client education that, you should be aware of. Okay, this is a quick cheat sheet. I added in here just so you know, okay, if it's fluid volume deficits, if there's not enough fluid or too much fluid, what happens to all of these different components, like your weight, your heart rate, blood pressure, your skin tear, edema, all of these things. And down here is your labs and clinical manifestations. So this will help you kind of, memorize those. Okay, so that was fluids. Let's talk about electrolyte imbalances. Remember, we said to maintain homeostasis, you need a balance of what? Fluids, electrolytes, and acid bases. So let's talk about electrolyte imbalances. Electrolytes are any of the various ions that regulate electric charge in the cells. We said we need those ions for electrical charges in the cells, right? They're charged ions dissolved in body fluids. Cations are the positively charged ones, anions are the negatively charged ones. So electrolytes, they're distributed between the intracellular space and the extracellular space. That means inside the cells and outside the cells. Some live inside the cells, some mainly live outside the cell, right? The distribution of these, ions differs in obviously intracellular and extracellular, and maintains cell excitability and allows for transmission of nerve impulses, because remember we said these ions are necessary for those nerve impulses. Body fluid should be electrically neutral, right? Not positive, too negative, right? And the positive charge ions, cations, are magnesium, potassium, sodium, and hydrogen. The negatively charged ones, the anions, are the phosphate, sulfate, chloride, bicarbonate, and protein ions. So let's look at electrolytes and its relation to homeostasis. Electrolytes regulate myocardial and neurological function. We mentioned this, right? There are certain ions, that help with the cardiac conductivity and pumping action, right? And also neurological function. Fluid balance, they help with fluid balance, they help with oxygen delivery, acid-base balance, and much, much more. The most serious and common abnormalities are usually sodium, potassium, and calcium. Kidneys work to keep those electrolyte concentrations in the blood. For example, when you're exercising a lot, right? Your potassium and sodium are lost through your sweating. So this requires an increased need for, potassium replacement, and that's where the kidney helps to do that. So the electrolytes also maintain voltages across all cell membranes, especially in the nerves, heart, muscle, through nerve impulses and muscle contractions. Remember the pumping action of the heart, nerve impulses from the spinal cord. All of those are required in your muscles, need electrolyte balances. So what could cause these imbalances? You can dehydration, overhydration, renal failure, chronic laxative abuse can cause that because you're losing, ions, right? Severe diarrhea or vomiting, bulimia, anorexia, nervosa, all of these can cause these imbalances. Potassium, but it's important to remember that potassium imbalances, are life-threatening, and these should be corrected immediately. And potassium imbalances usually are accompanied with magnesium deficiencies. So magnesium also has to be corrected to normalize the potassium levels. So what do you need to know about these electrolytes? You need to know the normal range. You need to know the basic function. What, the integrated body systems, where do they live? Extracellular or intracellular. The symptoms when there's an imbalance. For example, It can be hypo, that means low, or hyper, too much. So these are the things you need to know about electrolytes. I know it's very, the topic of electrolytes is, is very big, and there are a lot of electrolytes that you need to remember, but I created the cheat sheet for you guys. Please read over that. That does simplify quite a few things. But remember, you do need to read your chapter readings to help you understand it better, right? So you can have a wider knowledge of it. And it's also important to remember that cells exchange ions across cell membranes. Remember, we talked about diffusion, right? Disrupting this balance, like the movement of ions from, through these cell membranes here, can cause the cells to have negative changes, these imbalances, or have symptoms. This exchange happens through these channels. If you notice, like through the cell membranes, you have channels. That's where this exchange happens. Acid-base balance. You're going to cover this mostly in block 2, but I just want you to be familiar with, the concept. Acid-base balances, they should always be maintained in the body. Alteration can cause alkalosis or acidosis, depending on what the imbalance is. It involves 3 systems. You have the chemical buffer system. You have your hydrogen ions and your bicarbonate. Then you have your kidneys and your lungs. These are also involved in acid-base balance. It's determined by hydrogen ion concentration in the body fluids. Normal pH range, please remember, is 7.35 to 7.45. Anything less than 7.35 is considered acidotic. Anything more than 7.45 is considered alkalosis. And usually to measure these, we check ABGs, arterial blood gases. If you notice here, you put in you draw the blood from the arterial system. Okay. So let's talk about, a little bit more about your electrolytes. These are some major electrolytes. We have sodium, which lives in the extracellular space. That's the normal level. Calcium, it lives both in the extracellular and intracellular. That's the normal level. Potassium is an intracellular, ion. It's a cation. It's magnesium, it's intracellular. Chloride, extracellular. Phosphorus, intracellular. In block 1, we're going to focus on just sodium, calcium, potassium, and magnesium. So what is the education that we need to provide to our patients to prevent fluid and electrolyte imbalances, to prevent dehydration, to prevent hypervolemia? We need to teach them to increase fluids, right, are needed, and when temperatures are high, because we sweat a lot. So, they need to increase fluid. When they have a fever, you have an increased need for dehydration. GI losses, when a patient has diarrhea or draining wounds, you need to replace the fluids, right? And we encourage them to drink more, right? Now, they can also have fluid restrictions when they have, for example, heart failure, when they have hypervolemia. Then we need to teach them how they can measure their fluid restrictions. If it's 1,200 milliliters a day, then we need to help them measure how much, how much that is. For example, like this is a glass, it's 8 ounces, and we need to teach them all that stuff. We need to encourage them, to drink 8 to 10 ounces, 8 to 10 glasses, 8-ounce glasses of water a day, unless they are on fluid restrictions. Thirst is an early sign of dehydration, and it guides us to intake fluids. It's our body telling us to drink water. But older adults have a diminished thirst sensation, like we said. So we need to remind them to maybe keep a timer, or something to remind them. Colorless urine is a guide to hydration. That's one of the ways to, we look at the urine. It kind of tells us, okay, are they hydrated? Are they dehydrated? Usually darker urine is associated with dehydration. So this is over here is a urine color chart. Vigorous exercise can delay thirst mechanism. So we need to encourage patients who, participate in vigorous exercise to drink fluids regularly. They should drink before and after and during strenuous exercises. We need to encourage our patient to avoid the routine use of laxatives. This is seen a lot in older adults. They tend to take a lot of laxatives. or antacids, weight loss products, enemas, all of these can cause an imbalance of fluids, sodium and potassium, which is, like we said, life-threatening. We need to encourage them to weigh themselves daily, right? Daily weights, same time, same scale. Tell them, hey, if you're going, if you're going to wear this wake up in the morning, the best time is early in the morning. Tell them to use the same scale, dress similarly, for example, if they're dressed in a nightgown the first time and then the next day they go to check their weight, they're wearing a coat, obviously it's going to come, show that they're heavier, right? So it's important to teach them to do that. And we need to also let them know to contact the provider if there's a sudden change in weight. Remember, we mentioned that in class, decrease urine output, dependent edema, like for example, in their periphery, if they have any edema, right? You have shortness of breath, dizziness, prolonged vomiting and diarrhea, inability to tolerate fluids. All of these are things that they should report to their provider. We need to encourage them to eat a well-balanced diet, take oral electrolyte supplements, avoid salt substitutes because they tend to increase potassium levels. They have a lot of potassium in them. So if they're taking calcium supplements, they need to drink at least 2,500 milliliters of fluid daily. Okay, so let's move on to our 4 different electrolytes that we're going to discuss. Please refer to the electrolyte cheat sheet I gave you. It is also uploaded in your Canvas course. The first one is sodium. Like we said, we have hyponatremia, that's low sodium, and hypernatremia, that is high sodium. Sorry, I have it spelled incorrectly. That's supposed to be hypernatremia with an N for sodium, right? So hyponatremia, what are the causes? We have GI loss, NG suctioning, diuresis, too much water. You have chronic heart failure or liver failure. So basically, you have too much fluid in your body, and so your sodium concentration is low, right? But remember we said sodium, any imbalance of sodium, you're going to see neurological issues. So you're going to see confusion, lethargy. Your GI will be slow. You're going to start feeling muscle cramps. You can develop cerebral edema. Severe complications are seizures and a coma. Most of these are neurological problems. So when you think sodium, think volume, right? When the sodium is low, that means the volume is high. When the volume is low, then we know the sodium is high, right? Sodium, and over here I have a little mnemonic here with the little brain. Sodium swells the body to maintain blood pressure, right? Think of blood volume, right? pH balance. What happens when the sodium is low, depressed, and hypo, sodium, you're depressed and deflated. Neuro, heart, respiratory. These are just a few mnemonics over here that might help you remember. Then you have, what do you do when the patient has low sodium hyponatremia? You want to assess the neurological status, right? Because we said it can cause neurological issues, for example, seizures, cerebral edema. You want to assess for all those things. You want to monitor for signs and symptoms of fluid imbalances. You want to weigh them daily. You want to put them on a high sodium diet, right? Because their sodium is low, right? This is, what we do. And what are the treatments? Usually it's sodium chloride fluids or sodium chloride tablets. Hypernatremia, that's when your sodium is high, right? So that can mean that the volume is low. A patient might be dehydrated, so their blood is concentrated with that sodium. So you have, and what can cause this? People who have high sodium diets, they don't take enough water, right? They can have watery diarrhea. For example, a person just had C. diff, right? They lost a lot of, fluids. They can have osmotic diuresis. For example, patients who have diabetes tend to have osmotic diuresis because their blood sugars are high, and so they lose a lot of fluid. Then you have hyperpyrexia. That means you have extremely high fevers. It increases the metabolic demands in your body that can cause you to lose a lot of fluids through the sweating. Then you have severe burns. What happens in severe burns? The fluid from your vascular space goes into the surrounding tissues, which is called third spacing. And so now the fluid inside your vascular system then, and your cells, is then low. All right, so what do we do for this? The treatment is we replace the fluid. Sometimes we give them D5, D5 saline, we give them D5 fluids. We give them diuretics because they have too much fluid in their body, so we give them diuretics. So what are the signs and symptoms you're going to see? You're going to see tachycardia, a weak pulse, because remember we said when the fluid is low, what happens to the heart rate? It goes up to compensate, but your pulse is still going to be weak. It's not going to be bounding, right? Dry, sticky, thirsty, they can be dry in their mouth, sticky, thirsty tongue. They're always thirsty. Remember we said, that's a sign of dehydration, right? Neurologically, they're going to be confused, lethargic, agitated. So these are all neurological signs. Musculoskeletal wise, they're going to have twitches, twitches, and then eventually weakness, right? Starts with twitching, but then it leads to weakness. Then the DTRs will be decreased. Their, deep tendon reflexes. Over here, there's a little chart I put over here where you can check somebody, when you're checking somebody's deep tendon reflexes, this over here kind of tells you how we do that, so you can have your objective data. Severe side effects would be seizures, coma, and a brain bleed. What nursing interventions? Nursing interventions, when we're talking about nursing interventions, always look at the signs and symptoms, right? Because they're related to that. You want to assess their neuro and monitor the electrolytes, correct the sodium slowly, right? Because it can cause cerebral edema when you do it too fast. You want to monitor their I's and O's. I put this little picture here because just so you know, even though we're not covering, chloride, but sodium and chloride work hand in hand. So if sodium goes up, chloride goes up. Sodium goes down, chloride goes down. Okay, so let's move on to potassium. You have hypokalemia, and then you have hyperkalemia. Remember, hypo is low, hyper is high. So potassium, the normal level is 3.5 to 5 milliequivalents per liter of blood. And the causes, what are the causes of low potassium? Low potassium intake, easy, right? ETOH abuse, what's that? People who are alcoholics, they drink a lot of alcohol. That can cause low potassium. GI or renal losses, losing, like diarrhea or too much urinating, all of those can cause you to lose a lot of potassium. Diuretic use can cause you to lose potassium because what happens when you take a diuretics? You're going to pee a lot and you're going to lose potassium, right? Unless you're taking what we call a potassium-sparing diuretic, which we're going to cover, in our farm lab. So what are the treatments for this? Obviously, we're going to replace the potassium, right? Encourage a high potassium diet. For example, sports drinks, they have a lot of potassium, but we do need to keep an eye out for the sodium in them too, though. Okay, signs and symptoms. What are we going to see? We're going to see a weak heart rate, low. Blood pressure will be decreased, right? DTRs will be decreased. All of those things are decreased. GI will be slow, so everything is slow and decreased. And then in cardiovascular wise, you're going to see arrhythmias, abnormal heart rhythms, right? And the severe side effect is cardiac arrest. So remember, hypokalemia, everything slows down, you have arrhythmias, right? It's so slow that you can have a cardiac arrest, right? So what are the nursing interventions then? If you look at the signs and symptoms, you can guess the nursing interventions. You're going to monitor the electrolytes. Monitor them for falls. Why is that? Because remember, their heart rate is weak and low, their blood pressure is decreased, their deep tendon reflexes are decreased, everything is slow. So really slow. I'd like to say it, okay? And so, with that, you want to make sure that we monitor their electrolytes, monitor them for falls, because everything being slow. Give them PO, potassium, as ordered. We never crush extra release potassium, right? You want to, if you're giving potassium infusion, it needs to be slow. We never push potassium because it irritates the veins. Okay, what about when you have too much potassium? I put this little, icon here, the heart, the little image. And if you notice, when you think potassium, think electrical activity of the heart. Think just electrical activity when you're talking about potassium. So now when you have hyperkalemia, that's too much potassium, what are the causes? Too much potassium in the diet. Suppose say you're taking diuretics, but they're potassium sparing diuretics. So what happens? You're diuresing, you're losing water, but it's sparing the potassium. That means it's not excreting the potassium, it's holding it in. And so that can cause your potassium levels to go higher. Severe burns can cause potassium, right? And then you have renal failure. That's also potassium. Because why do burns cause, hyperkalemia? Because, you're losing your intracellular potassium. Okay, renal failure can also cause potassium because remember, the kidney regulates potassium. And so if you have renal failure, then it's not regulating the potassium and the potassium can go up. And what would be the treatments? The goal is to move the potassium to the cells. We want the potassium inside the cell, not anywhere else inside the cell. It's an intracellular cation, and we need it inside the cell. You want to give them calcium gluconate, which helps to, increase the potassium. Then you want to give them sodium bicarb, and they might need dialysis. Especially if they have hyperkalemia, you might have to get dialyzed to get that extra potassium out. So what are the signs and symptoms you're going to see? You're going to see heart rate is low, blood pressure is low. You're going to see ECG, changes, arrhythmias. Basically, they're used interchangeably. Arrhythmias and dysrhythmias, they're basically the same thing. You're going to see that on their EKG. But their GI is going to be hyperactive. Their muscles are going to cramp first, and then when it goes too high, then it's going to lead to weakness. It can also cause cardiac arrest. If you notice, a lot of the things are very similar between low potassium and high potassium, except for the GI. The GI is hyperactive in hyperkalemia and slow in hypokalemia, right? So now when they have too much potassium, what do we want to do? Monitor electrolytes, monitor the EKG, because remember, they're going to have arrhythmias, dysrhythmias. Then you want to monitor for falls, right? If their blood pressure is low, their heart rate is low, they may fall, right? Then we want to make sure that they don't get any potassium in their diet because they already have high potassium. So over here, again, there's a few more mnemonics if you want to look at it. If you notice here, it says potassium priority pumps the heart and muscles, right? Then you have hypo, what happens? Low and slow, right? Hyper, tight and contracted. Okay, so let's move on to magnesium. When you think magnesium, think neuromusculoskeletal and cardio. So we have hypomagnesemia, that's too low magnesium, then hypermagnesemia, that is too high magnesium. So what are the causes? A lot of times when you hear magnesium imbalances, it's usually, a lot of times, not all the time, but alcohol related, right? Chronic alcohol abuse can cause low magnesium levels. DKA, diabetic ketoacidosis, can cause low magnesium levels. GI losses can cause, that as well. Renal disease, again, pancreatitis, and malnutrition can cause, low magnesium. Treatments are we replace the magnesium, either by mouth or through IV. Signs and symptoms, what are we going to see? We're going to see crazy wild, like it says over here. When it's low, you're going to see crazy wild. You're going to have tachycardia. Your neuro is going to be irritable. Altered AMS means altered mental status. You're going to have altered mental status. You're going to have confusion. Cardiovascular wise, what are you going to see? You're going to see dysrhythmias. Your heart is irritated too. You're going to see muscle cramping. You're going to see that your deep tendon reflexes are going to be high. That means they're hyperactive. You're going to see the positive Chvostek and Trousseau signs. The Chvostek sign is when you touch the cheek, you'll see that it twitches. The Trousseau sign is when you touch check the patient's blood pressure, and I'm going to show you that when we talk about calcium. When you, tighten the blood pressure cuff on the patient's hand, their hand will twist, right, towards, their upwards. And there's a picture on the next slide, and you'll get the chance to look at it. And a severe side effect of low magnesium is seizures, because think of it, everything is going crazy and wild, right? And seizures is crazy and wild. And so everything is just going high over here, right? Tachycardia, irritable, neuro-wise, musculoskeletal cramping, DTRs are high. You have the, and seizures. What are the nursing interventions? Now, what do we want to monitor them for? We want to monitor their vital signs, right? Because they have tachycardia. You want to monitor the cardiac rhythms. Why? Because it causes dysrhythmias, right? You want to monitor their neuro and musculoskeletal status because, and you want to also give them a high magnesium diet. So now this is the opposite of hypomagnesemia. When there's too much magnesium, what happens? Causes can be severe metabolic acidosis, renal failure, and trauma. Because remember, the kidney regulates electrolytes. And so if you have renal failure or renal disease, that's going to mess with your electrolytes. So they're going to be off balance. Trauma can also cause, hypermagnesemia. What are the treatments? Discontinue any magnesium medications. They may need dialysis to, balance it. You want to you want to reverse it with calcium gluconate. Calcium gluconate is the antidote for hypermagnesium. You can reverse it. So what are the signs and symptoms that you're going to see? They're going to be opposite to when you had too low magnesium. So everything is going to be slow, calm, and quiet, like it says right here. All right, what's going to happen? Your vital signs are going to be all low. Heart rate, blood pressure, respirations, everything will be low. Neuro-wise, you're going to be lethargic and drowsy. Musculoskeletal-wise, you're going to be low. Your DTRs will be low, and that can cause an increase and can also cause an increased bleeding risk. So now that this is, if you notice over here, it's crazy and wild when you have too little magnesium, can lead to seizures, right? And when magnesium is too high, it can lead to coma and respiratory depression. Why? Distress, because everything is too low. So what are the nursing interventions? We want to monitor vital signs. We want to monitor the cardiac rhythms. We want to monitor their respiratory, because guess what? They're at risk for respiratory depression, respiratory distress, right? Then you want to check check for bleeding, any, bruising or anything like that. You want to put them on fall precautions because what? Everything is very low, and so they can fall. Okay. Now let's talk about calcium. Calcium, when you think calcium, think muscle. Calcium affects your muscle. Remember we said calcium calms, right? So if you have too low calcium, what do you think is going to happen, right? It can be caused because of ETOH, alcohol abuse, pancreatitis, chronic renal failure. CRF, I put over here, is chronic renal failure, low vitamin D, right? Taking loop diuretics can also cause you to lose potassium. Hypomagnesemia. Magnesium and calcium kind of, go together. And so if you have low magnesium, you can have low calcium as well. So replace the calcium. That's the goal. That's how we treat it. Either it's PO or IV. Replace the calcium. What are the signs and symptoms we're going to see? Your heart rate and blood pressure will be low. Neuro will be irritable and confused. Cardiovascular, your cardiac output will be low. Your GI will be hyper, right? Your musculoskeletal wise, you're twitching. You have spasms. DTRs are high. You're, hyperreflexive, right? You have a positive Chvostek and Trousseau sign. Seizures, you're going to be, hyper, because remember, calcium calms. So if you don't have enough, everything is going to be irritable and high and crazy, except for your vital signs over here. Your heart rate and blood pressure will be low, but everything else over here, as you can see, is hyper, right? And your cardiac output obviously is low because your heart rate and blood pressure are low. Okay, and then everything being too fast and hyper can cause seizures. Then you have your nursing interventions. What do we do for people when they have too little calcium, right? As a nurse, you're going to monitor their electrolytes, monitor their vital signs and bleeding, assess for neuro, muscular spasms, paresthesias, and tetany. You want to assess for all of those, okay? And what happens with hypercalcemia? Calcemia. So that's when you have too much calcium. We said calcium calms, right? So when you have too much calcium, what can happen? First of all, let's see what causes it. Prolonged immobility causes too much calcium circulating in your blood, dehydration, cancer, excessive antacids, especially calcium antacids, the Tums we take, they have a lot of calcium in them. Vitamin D or excessive vitamin D. You have a parathyroid hormone, then what happens? It's releasing a lot more calcium into the blood. And what are the signs and symptoms we're going to see? Vital signs, you're going to see that you have hypertension, your heart rate is low, okay? For cardiovascular, you're going to see ECG changes, not ECH, sorry, that's ECG changes. For GI, it's going to be slow. Musculoskeletal is going to be weak. You're going to see bone and joint pain. Your DTR, deep tendon reflexes, are going to be low. And how do we treat this? We correct the cause. We give IV fluids, loop diuretics to remove the calcium. Too much calcium in the blood. We need to remove it, right? And if you notice over here, what are the severe side effects that they're going to have? The signs and symptoms. I'm sorry, I had to put it here to kind of balance the space on this sheet. So the signs and symptoms, remember we said calcium calms. It calms so much that it can cause a coma, right? And over here, too little calcium can cause seizures. So it can cause fractures. Too much calcium can cause fractures and kidney failure as well. So we want to monitor their electrolytes, monitor their vital signs, monitor their blood pressure, encourage ambulation, because remember, you don't want to promote immobility because prolonged immobility can cause hypercalcemia. You want to ambulate the patient. You want to hydrate the patient. And over here, I put this little image here, just even though we're not covering phosphorus, but it'll be good for you to know that phosphorus and calcium have an inverse relationship. So if calcium is high, phosphorus is low. As calcium is low, phosphorus will be high. Over here, there's another, mnemonic. You have keep the 3 B's strong: bones, blood, and heartbeats. Hypo is crazy wild. Hyper is swollen and slow. Moans and groans and stones. Kidney stones, like calcium, because they're calcium. Calm and quiet. Heart, DTRs, lungs, GI. And if you notice over here, this is the Chvostek signs. If you tap on the cheek, you'll see a twitch. Trousseau signs, if you put the blood pressure cuff on and you tighten it to check the blood pressure, you'll notice the hand will point upwards and the fingers will be twisted. So one thing to remember too is that a lot of these electrolytes have inverse and, similar relationships. And in one of the slides earlier, there's a chart there showing which ones have inverse relationships, which ones have, similar relationship. This helps to kind of remember. Like, for example, if you notice that the patient has high calcium, you're going to expect that the phosphorus will be low, right? That's a good thing to remember. And that is it for your fluid and electrolytes lecture. And please review your cheat sheet and make sure you take your notes on your guided notes. That will help you to, kind of focus on all the important information. And I will see you in class.